There is an announcement for the participants. E-certificate will be issued to only E-certificate will be issued to only those participants who will submit their feedback form and qualify the online assessment. The feedback form has to be filled at the end of each day till 8 p.m. The submission of feedback form shall be counted as their attendance. The online assessment shall be conducted at the end of these stages of STTP. The link for the submission of feedback form has been posted in YouTube chat box and Google Meet chat box. Kindly go through it and submit it. Now, starting our third session, we are fortunate to have with us Dr. Satish Chandra Bachar as our guest speaker for this session. Dr. Shadeesh Bachar is working as a professor in the Department of Pharmacy, Faculty of Pharmacy, University of Dhaka, Bangladesh. He received his B.Pharm and M.Pharm degree from the University of Dhaka. Professor Bachar was awarded a PhD in pharmacy from Jadavpur University, Calcutta in 1996. He was a postdoctoral fellow during April 2004 to April 2006 under the Ministry of Health, Kingdom of Saudi Arab through Department of Pharmacy, King Faisal University in Safe Drug Use Management. Dr. Bachar is a well-recognized medicinal chemist with expertise in the synthesis of Indian-based anti-inflammatory analgesic, plant growth regulatory compound, and structure activity studies. Professor Bachar has been successfully in securing a number of research grants to support his research. Dr. Bachar has the opportunity to publish several publications in higher impact international journals in the area of medicinal and natural product chemistry. Professor Bachar is a member of various professionals and volunteer organizations. He has also General Editor Advisory Membership grant reviewing the general article reviewing expertise. We welcome you, sir. May I request sir to start with his deliberation, please, sir.
Thank you, Dr. Ruchi Bhattacharya, and I'm express my gratitude to Dr. Amit Roy, Mr. Harjit Singh Ura, and Janpat Education Institutions members, dignitaries, Honorable Vice Chancellor, my colleagues, those who are linked in here till today as 21, and the students of the various institutions. I fortunately have to visit, to participate in a conference held in 2014, October 10 to 12, organized by Colombian Institute of Pharmacy. And so I have a good link with Professor Amit and Mr. Harjit Singh Hura. So there is relationship, and I am very happy to all of them to invite these organizations and this STT training of the, especially for the teachers. But I would like to share my ideas in terms of the experience, what I have earned for professional achievement for as well as for human resource development as a pharmacist. So now I would like to share my views about the activities where I am involved with the graduate pharmacist and pharmacy practice, those who are providing the healthcare delivery service. And this definitely this short-term training program, especially for the teachings, sponsored by All India Council for Technical Educations and organized by the Colombian Institute of Pharmacy, Raipur, Chhattisgarh. And I am very much thankful to all of you for giving me the opportunity to say something regarding the matter. As you know all, the graduate pharmacist working in institutions, hospitals, and community pharmacy services and responsible for ensuring the safe, appropriate, and cost-effective medicines. And they work collaboratively with other healthcare professionals like doctor and nurses, the key medical or healthcare professionals in the healthcare settings to ensure the most appropriate drug use management in the patients, and pharmacists are collaborating them nicely, mostly in the developed countries. But these things is not as much we are expecting in the in Asian, especially Bangladesh, even in India. Pharmacy practice is one of the most vital part of an institutions and hospital and community for better patient care and drug safety management. We know World Health Organization recommends that standard pharmacy practice should be carried out under the supervision of a professionally competent and legally qualified graduate pharmacist. This is evident. We know we always taking the a lecture to the students, this citing such kinds of example to our students. So, who again clearly recommends that the management of drug procurement, storage, and distribution should be the responsibility of a graduate pharmacist. One study has shown that higher level of hospitalization for patients who have poor adherence compared to patients who have proper adherence. So when we adhere about the prescriptions, how, when, why the medication have to be taken, that when the pharmacist will explain it to the patients, that is proper adherence. And if it is not happened, there is poor adherence and the hospitalization is increased. So the suffering of the patients is increased and out-of-pocket expenditure is definitely increased. Another study has revealed significant improvement on patients' knowledge and attitudes when clinical pharmacists provide health care education to patients, when thus offer a positive impact on treatment outcomes. So this is an impact. This I shall give some two examples in the inpatient healthcare settings in a tertiary care hospitals in Bangladesh, because I am directly involved with the medication management use in these tertiary care hospitals. So I would like to brief introductions on the present scenario of the pharmacy practice in Bangladesh. So that's why I would like to know a little bit highlight on pharmacy practice, innovation in pharmacy practice, and little bit in our discussions, the mission and vision of the pharmacy practice in a nutshell. So what we define in the classroom, the pharmacy, it is a patient-oriented healthcare that applies scientific knowledge to improve and to promote health through assurance of safety and efficacy of drug therapy. It is evident. It is a definitions in the books. Always we are giving information to our students in the classes. So pharmacy professions or pharmaceutical care in terms of patient care is still unreachable, and it is our vision and mission to achieve this pharmacy profession to our patients as well as to our other healthcare providers as a benefit, because pharmacy always they have the benefit to provide to the professional benefit to the doctor, to the nurses, to the patients. So that is yet to achieve our vision and mission in terms of pharmaceutical care or in totality of patient care from the pharmaceutical point of view. So it is especially in Asia, India, Bangladesh, Nepal, Sri Lanka, even in India. So pharmacists, where they work actually globally, because we'd like to share some about the global scenario of pharmacy where they are involved, especially in community pharmacy. In globally, in community pharmacists are involved about 55% graduate pharmacists are involved in community pharmacy in America, Canada, Europe, even Korea, Japan, New Zealand, Australia. All graduate pharmacists, they are professionally they're providing service to the community people. But we know pharmacist is the first point of contact in a community setup on matters related to drug and drug use, because he comes in contact with more patients than any other healthcare professional, especially the doctor. Because you see, in our hospital settings is mostly in a besides of a doctor's clinic, and if we compare with the pharmacy and the doctor's clinic, the number of patients visiting to the pharmacy is more than the patients those who are visiting to the doctor's clinic, because most of the cases, science, the patients need some medicines, especially without prescriptions, because some minor ailments. But if that case, in our scenario in Bangladesh, because there is no such qualified pharmacist in the society who can really contribute to the patients, as a result, the antibiotic resistance and inappropriate use of medication is increased. And the scenario of the antibiotic resistance program is a burden all over the world, including India as well as in Bangladesh. So, in hospital pharmacy, including the government, private, and clinical pharmacy, only 30%, more than 30%, a good scenario, because pharmacists are mostly involved in 30% in developed countries as globally. And in manufacturing, only 5%, but the scenario is totally different in India and Bangladesh. And for government agencies, only 5%, especially the DCGI, FDA, in that cases, because in academic institutions, only 5%, and total scenario is this. So if we compare this scenario to our present situations in India and Bangladesh, is totally different. Most of the pharmacists are involved in manufacturing and academic institutions, and a little bit in government agencies, but the community pharmacy and hospital pharmacy, the number of graduate pharmacists is totally reversed, is very less. And the benefit of the pharmacist, the patients, the doctors, the nurses are not getting properly. So that is the mismanagement, or the medication use management is not properly happened in our countries or in Asia, you can say. So pharmacy practice, as it has developed, implies in the area of operation of pharmacy activities in an institution, hospitals, and the community. And it deals with mainly the human lives, safety, and ethics. And we are all about this matter, or we are all concerned about this matter, because pharmacy practice is such a profession we have to deal with the human lives sitting or standing on the patient's bedside. So the practicing professionals are the real image builder of any professions, including the teaching professions also. The public evaluate a professions through the capability and competence of the members of that professions, but that is not also different from the teaching professions, because when you are teaching students, you definitely have to plan of your educations, plan of your topics, plan of your subject matter. Then you have to go to the classes, and then after classing, you have to go for assessment, then for evaluation. So you have, and how are you dealing with this matter with your students, that is reflected to them, and that is create a building and a confidence on you. So that is this practice definitely create an image building of your professions. So that is also implicated for the teaching, as well as in terms of pharmacy professions, that is very much inevitable. So how the pharmacy is dealing in the society in terms of providing service, pharmaceutical service to the patients, to the doctors, and the nurses, that is also depending on its capabilities and competencies. That is the public or the respective stakeholders evaluate these things. So pharmacy practice is basically we deals with here is the pharmaceutical care, definitely deals with the pharmacoeconomics, pharmacovigilance, healthcare team concepts, and medication. And in the next slides, I shall try my best to discuss regarding these matters in terms of pharmacy practice. So, being a professionals, we have to love our professions like a mother who who take care of her child. So, being a pharmacist, being a teacher, we have to love our professions like a mother to her child. So that is the very important things for any kinds of profession. So in terms of pharmacy professions, that is also inevitable. A profession or the pharmacy profession, how a pharmacist is dealing with in terms of the governing of by regulations, ethical and professional principles and norms, because you have to obey all the ethical standards of the pharmacy professions, and that will definitely be the credibility of a professions depending on this ability, how he or she is performing professionally. So this is also related with the pharmacist as well as to the teaching professions. So now I would like to give some glimpse of ideas what being a pharmacist or the professionals as how I am being training or developed training materials to the pharmacist in a healthcare settings, so that should I let you know and what should be the future practice of the pharmacy practice in a hospital settings, that I will let you know all. So first of all, the pharmacy graduates activity in a hospital should be these different sections. So first of all, the dispensing area, you'll call outpatient, inpatients, floor stocks and controlled narcotic drug dispensing systems, drug information services, dealing with the education and training, drug inventory management, quality improvement of the professionals dealing with these respective sections he or she is responsible, and the compounding activities in terms of extemporaneous preparations, total parenteral nutrition, this antibiotic stewardships, then anti-cancer drug admixtures, and definitely finally have some research activities. I shall give you 1-2 examples of how a pharmacist involved in the tertiary care hospitals with the research program also. So how the pharmacists are providing pharmaceutical care in inpatients activities in the tertiary care hospitals. First of all, the doctors are writing the prescriptions. That prescriptions is going through the online system to the pharmacist module, and they received it because before it was coming to the scan and photocopy. Now it is going through the online systems, and this pharmacist is now receiving it. After receiving online, he is reviewing the prescriptions reviewing the prescriptions. After reviewing, checking the appropriateness of the prescriptions regarding the dose, drug-drug interactions, patients, prescription criteria, everything. Then he is sending to the other assistant. Then he or she is transcribing the prescriptions, creating a bill or the patient's head. After creating the bills, they go to the patient attendant or pharmacy attendant. That pharmacy attendant is selecting the drug with the prescriptions and bill, selecting the drug, making package and making labeling. After completing these things, it is giving in front of the another pharmacist who is checking the appropriateness of the prescriptions dispensed by the attendant and billing by the assistant. So he is checking prescription, drug, and the bills. After finalizing these things, he is sending dispensed medicine for the patients, which will be sent to the ward by a patient care attendant. And when the prescription is going to the patient's bedside, the respective nurses or responsible nurses take the medications regarding what she sent or he sent to the pharmacist for regarding the requisition. And definitely after checking all these things, the patient or nurses or the sister will sign the copy, and that will be kept in a pharmacy and kept in a regular file. for any incidents for future incident if things wrong is happening there. So drug arrangement, the pharmacy is basically happening in this tertiary care hospitals in alphabetically regarding the patient's trade and generic names. We know about this unit dose drug distribution system because basically it is an American. It is called American unit dose distribution systems because the drug is basically sent to the patients for 24 hours basis. So there have some distinct elements of these basic rules. What medications contained in a single unit package, they are dispensed in as ready to administered form as possible, because almost 99% or more than this, the medications are in ready to administered form. And for most medications are not more than 4 hours supply of doses is delivered to or available at the patient's care area at any time. So this is the definitions and distinct benefits or elements of this unit dose distribution system. We all know everything because we are teaching these materials as a pharmacy practice in the hospital settings. So in the tertiary care hospitals, the name of the hospital is Score Hospitals Limited. It is a good reputed hospital in Bangladesh because these prescriptions, there's 2 prescriptions is here. One is only inpatient prescriptions is left side, and the right hand side is the once-only prescriptions called this is once-only prescription. That is not emergency prescriptions because only created once only, and that prescriptions is repeatedly done by the person because there is 2 sides. One side is dictations for the doctors, the other side is the activities of the nurses. The doctor, everything should by generic name, dose and frequency, and everywhere he put his or her sign, and this part will be signed by the respective nurse depending on the when he or she is administering the patient to the patients. So when these prescriptions will come to the pharmacy online, so this is the pharmacist receive the prescription on the basis of the patient's aid on the responsible doctor who is prescribing. So after selecting these things and the respective medicines from the online or this database, this online prescription of billing is created. Such a way the bill is created because you see in the right hand prescriptions 1 item, 2 items, maximum 3 items is dispensed for the patients according to the prescription written by the doctor. So medicine dispensed. So when the prescriptions is come, then a pharmacy assistant receive with a tray with the prescriptions and bill, and accordingly he is picking up the medications what is required or what is prescribed by the doctor. And after selecting the medication from the medication rack to assess the right medicines, right drug, right dose, right the pharmacist, so he is checking the registrations hard copy, these prescriptions, requisition or prescription hard copy, pill copy, and the unit dose medications. So these 3 things, when combined these things, this is how he is assuring right medicine, right drug, right time, right patients. So after dispensing, completion of the dispensing activities, this identifying the each medications, each bag is or container is for each patient. So the respective attendant are reaching or carrying the medications to the respective wards and will deliver to the respective patients. So product quality checked by graduate pharmacist in the hospital settings, and a storage of the cold chain medications because some of the medications must be have to storage according to the status conditions, according to the manufacturer's instructions. And this is also the same activities of pharmaceutical care provided in a outpatient. This is all about, we discussed with the inpatient activities about the regarding the pharmaceutical care from the inpatient drug dispensing systems. Now we are discussing about little bit with the outpatient dispensing pharmacy, the same manner online prescriptions received, the doctor write the prescription, online prescription received, patient decisions and payment, transcription and billing, selections, packaging, labeling, and medications bill and prescription cross-checked by the graduate pharmacist, then call the medications and then dispensing to the patients. So this is one kind of examples. A pharmacist is a graduate pharmacist, counseling the patients about his medications and also adhering with the prescriptions when and how has to be taken the medications to the patients. So this is the graduate pharmacist also involved in the extemporaneous preparations, as you told you before, in compounding activities, because I told you before, more than 99% medications is ready to administer from. Even then, some of the medications for geriatric or also some neonatal or pediatrics, some of the medications are required to be dispensed or prepared according to the dose mentioned by the doctor, and that is done by a extemporaneous preparation activities in the hospital settings. Definitely, the pharmacist is also involved in the total parental nutrition, because some of the patients, those who are advised nothing per oral or not to take any medication or anything through mouth, in that case, is depending on the condition of the patients. So to supply his total nutrition, sometimes we administer it totally parenterally. So carbohydrate, fat, proteins, vitamins, minerals, water, everything administered together and have given to the patients. And that is another special criteria for administering the total parental nutrition to be supplied to the patients' respective wards. And that is a very important part that we are contributing here in Bangladesh, in tertiary care hospitals, the graduate pharmacy in a clinical pharmacy service, especially in intensive care unit. Because this, you see the clinical pharmacist is working in the patient's bedside, assessing the prescriptions, assessing the drug-drug interactions, monitoring the medications, whether it is being benefited to the patients or not, even assessing the antibiotic rational prescription writing, effectiveness, whether the medications is already, especially the antibiotics, is already developed resistance or not, is being assessed by the pharmacist. And always the clinicians are requesting the patient, the pharmacist, regarding the appropriate use of antibiotics in the intensive care units, because most of the patients are taking a good number of medications, more than 10 to 20 medications they are getting. Clinical pharmacy service by the clinical pharmacy, because as I told you before, this clinical pharmacist, he's also a graduate pharmacist. He is dealing with the medication safety, accuracy of the medications, and definitely in terms of pharmacoeconomics, cost-effective medications is being dealt with by the pharmacist or by the hospitals as well. So what is her activities? Checking and monitoring the interactions among prescribed drugs of the prescription, close monitoring of the prescribed antibiotics, dosage schedule, therapeutic effectiveness and calculation of the doses, therapeutic drug monitoring, and pharmacokinetic evaluations of the medicines with corresponding to suggestions to doctor. I shall give you one example in a case study. Continuous clinical drug-related informations and interrelations, international updates to doctors and nurses, because regarding these selections, because we have to update regarding medications always to the patients, the international related information from international and national, especially the updated journals. Definitely, as a part of pharmacovigilance activities, the adverse drug reaction monitoring, awareness building, and reporting to the pharmacy and therapeutic committee and our national regulatory body, Director General of Drug Administration Bangladesh, always providing the information to them. So that is the things. And definitely now we have started for a skin test for avoiding severe adverse drug reactions in our hospitals. So, the pharmacovigilance is defined as the, because I always discuss about this matter to make it short and to time consuming matter, I'm just skipping in because all of you are very much aware about this matter. So I was giving some evidence. So this is the matter we're always discussing in our pharmacy and therapeutic committee of the tertiary care hospitals. And when this is assessed, after that we are sending to the Director General of Drug Administration, the regulatory bodies. Before sending to the regulatory bodies, we are fulfilling the right-hand side the form, that is a suspected adverse event reporting form. And we have another suspected adverse event reporting form in our hospital settings we developed ourselves, and we are practicing before the government initiatives. From the since inceptions of these hospitals in 2006, we have started under my supervisions or under my active supervisions or activities. We started these things until now. We are now working with the government as well. So this is the scenario, because it is a Stephen Johnson syndrome experience by the patients, and she recovered after the incident. We also provide high alert medications, very, very important issues in any hospital setting, because according to the Institute of Safe Medication Practice of America, the high alert medications are drugs that bear a heightened risk of causes significant patient harm when used in error, because dose rate, dose increased is very, very important. That's why we made some mistake regarding this matter. So because we have so many examples, so I shall try my best to one examples here. So these are the respectable drugs where we need to be high alert. So because we are providing the red strip mentioning the high alert and to be given to the patients in a definite rate, and that would fix to the machine of the in the respective intensive care unit or any ward, because the medications are especially insulin, opiates and narcotics, potassium chloride or concentrated potassium solution, intravenous anticoagulants, especially heparins, and definitely the sodium chloride solutions, especially 0.9% as well as 0.3%. Just one example I would like to share with you, all of you. One patient in our Chittagong district, one patient was admitted to the Skar hospitals, the tertiary care hospitals in Dhaka, with a incoordinations, with a history that the patient was given 3% sodium chloride with a higher rate when he was admitted in the clinic, because the patient was developed hyponatremia. To adjust this hyponatremia, doctors advise 3% sodium chloride to the patients. But the sister who administered the patient the 3% sodium chloride, he deals with a straight a high rate, and the patients developed the unconsciousness, because the patient this high concentration of sodium chloride in demyelination of the nerve cell. Demyelination of the nerve cells, because when the impulse is not properly conducted. So regarding the demyelinations of the nerve cells, so that is creating a problem to the patients, and finally the patient was not survived. So this is very important. That's why high alert medications is very, very important in the tertiary care hospitals, especially even secondary care also. Admixture of anti-cancer drugs by the competent graduate pharmacist in these tertiary care hospitals. There is a dedicated 2 pharmacists in different schedule to admixture and counseling of the patients regarding the anti-cancer protocols with the patients. So that is bring a benefit to the patients as well as to the healthcare providers, especially doctors and nurses. Graduate pharmacists also providing information to the doctors and nurses. It's also a service. The pharmacist always providing information to the doctors upon his or her request. So another important thing is look-alike medications. So medications error or administration error, because you see there is a almost similar. This left-hand side is amikacin, 100 milligram, and right-hand side is chlorpromazine hydrochloride. That is only double band. So when the medication is kept in the patient's cabinet, so it is very much difficult to identify the medication. So it may confuse to the nurses. So these things have to be care about when the patient's sister or brother is giving medications or administering medication to the patients. He or she have to be assured, if not possible, ask to his colleagues whether he or she is giving the right medication to the patients. So this is very important things. So when this regarding this matter, when I was one incident was happened in hospitals, the patients was given atracurium, pancuronium bromide, the master relaxant to the patient because he was in a critical conditions. So he needs to be relaxed in the hospitals. In that respect, the patient was given atracurium or pancuronium bromide with a gentamicin injection. But when it's found the patient has recovered, the patient did not need any muscle relaxant, pancuronium or atracurium, but one ampule is remain in the cabinet. But his or her antibiotic schedule is continuing. So she was given the gentamicin injections, but gentamicin and this pancuronium bromide ampule is almost similar to look. And the sister pick up the atracurium instead of gentamicin and give to the patients. And when it is because when we are giving the muscle relaxant, definitely the patient needs to be intubation, and it was not happening because the patient is recovering, and the next day the patient will be discharged, and without supporting to the ventilation, when the patients given to the medication, the atracurium, pancuronium is given to the patients developed hypoxia. And when all muscle relaxant is decreased because his respiratory observed, this patient is fighting for survival, and ultimately the patient died. So that is important for lookalike medications. So they have to be the doctor, especially the sister and the brother, have to check the medications before giving the medication, because always the hospital pharmacists are requesting the sisters and brothers because check the medications before giving to the patients. So there is a potential drug-drug interactions in monitoring, because when we are not checking the medications, sometimes regarding the polypharmacy, because in the hospital settings, in an intensive care unit, because most of the patients are getting good number of medicines, so that may create a chances of antibiotic resistance to the patients. So that is a evidence-based suggestions have to be given to the doctors so that we can reduce the drug-drug interactions. I'd like to share two case studies. Here is one. So because one patient is 63 years old age, he was suspected to adverse drug reactions of phenobarbital at the district level hospitals in 2018. Second suspected drug of ADR was naproxen. It's in a tertiary care hospital, privately hospitals in Dhaka, and it was happening in 2005 after 1 month almost. And again, suspected drug was naproxen in other tertiary care hospitals in Dhaka is after 3 days. Then the patients came to the hospitals, it is core hospitals, and it was identified that it was happened due to the third generation cefixime. And during that period, the patient was continuing these things. And finally, the patients died and patients were admitted in the hospitals in 2905 and died 2018. So that is a great, because pharmacists in the settings, in most of the healthcare settings in Bangladesh is absent. In Bangladesh also, few tertiary, privately owned tertiary care hospitals, they are recruiting some good number of pharmacists only. In government settings, there is no pharmacist. So, as an evidence of the research activities, you see, so here the prescriptions, the blood culture of the routine, the sensitivity pattern of the antibiotics, all kinds of antibiotics are resistant. You have include the polymyxin, meropenem, colistin, tigecyclines, all are resistant. So when the blood sample is taken to the patients regarding this matter, when even the tigecycline is resistant, the the graduate pharmacist advise to the clinicians in the intensive care unit to increase the dose of the tigecycline double on the basis of the literature. And that experience has been published in Elsevier publications. So this is the evidence of the SCOR hospitals of the appropriate use of antibiotics. You see, this is happening. The second case studies is another male patient, and she was suspected to septic shock. It is condition of septic shock, acute exacerbation of COPD, diabetes mellitus, hypertension, acute kidney infections on acute kidney disease. And his clinical problems was found as drug-induced sudden raised in blood pressure and tachycardia. And why it has happened? Because of his clinical conditions or disease conditions, patients was advised to control his blood pressure with inotropes, that is noradrenaline, at a dose of 0.01 to 0.035 microgram per ml per minute. And because of its infection, shock, septic shock, and COPD as well, he was also advised to take linezolid 600 milligram 12 hourly. After giving these medications, the patient's blood pressure was actually raised rapidly to 190 by 100 with significant tachycardia of 130 beat per minute. And then the clinical pharmacist was called, and he found that with the literature, the linezolid is a weak monoamine oxidase inhibitor, increase the effects of noradrenaline by pharmacokinetic synergism and risk of acute hypertensive episodes. And that is the evidence. When this information is conveyed to the doctor, all on a sudden, the doctor reduce the dose of the noradrenaline and patients come to the normal position. This is the benefit of the pharmacist in the healthcare settings. The second evidence in the hospitals, the patients was diabetes mellitus, hypertension, and chronic kidney disease and nephrolithiasis. The patients were taking about 16 drugs. One was diltiazem with arrhythmia, cardiac arrhythmia, and another was the patients need to be sedations. So he was advised to give midazolam, 7.5 milligram once a day. After giving the midazolam to the patients developed a prolonged sedation and impaired coordinations, confusion, somnolence, and diminished reflex. So that creates a confusion to the patient attendant also. Also confusions to the doctors also. What happened? So then pharmacist was called and the pharmacist checked. She told that midazolam is an ultra short-acting benzodiazepines and it is metabolized by cytochrome P453A isozymes, and these isozymes are inhibited by concurrent medications like diltiazem, which may have an effect on recovery from the sedation. Because of these things, the half-life of the midazolam is increased because the competitive is in the receptor side, because the diltiazem is occupied by the receptor side and inhibiting the metabolism of midazolam and increasing his half-life. That's why the patient is not getting up. So when the patient pharmacy informed about the situation to the consultant, within a minute, this dose of the diltiazem withdrawn and patients recovered. And that may be happened because of in both the cases, both the dose is reduced into the 50%. It would no problems. But that is the pharmacokinetic interactions. A pharmacist can give a good benefit to the doctor, even to the patients. So that is the why the number of staying of the hospitals is increased due to inappropriate use of medications. In that cases, pharmacists can give a good benefit. In Bangladesh, we have also created an opportunity for the graduate pharmacy in the creating a model pharmacy initiatives in Bangladesh and model medicine shop. But the concept was not properly done due to some problems of the pharmacy owner, as well as responsibility of these regulatory bodies, and even there have some problems of the pharmacist. I'm not detailing about this matter. So it was a good initiative, but the society, we are not able to provide the benefit to the pharmacist to the give. But there have in a number of pharmacists still working in the model pharmacy in Bangladesh. I am discussing these things. So in Bangladesh, in Dhaka University, the pharmacy course is 5 years course, mostly exposure to the clinical subjects. So according to the syllabus, the students have to spend 6 months, 4 hours in a week, 4 hours in a day in the tertiary hospitals, especially government hospitals, Dhaka Medical College hospitals. So I am giving an evidence of these pharmacy students discussing regarding the medications or use of medications or toxicities of the medications with the doctor or registrar of the hospitals. So this is an evidence of the Dhaka University students as an exposure of the hospital training or clinical training or clinical exposure. They are working in a 600 hours, that is 6 months, twice in a week, sorry, 6 days in a week, 4 hours from 9 to 1 every day, and they are getting support from the respective because they're working in pediatrics, working in nephrology, working in cardiology, in medicine, surgery, emergency, and pharmacy. So all area, this is the area we have covered, and this is some evidence of the pediatric sections also. The pharmacists are checking the medications with the expiry date, sent to the ward. They are discussing with the patient attendant's mother of the patients regarding his present condition. The students are also observing a patient admitted with a meningococcal encephalitis, and patient will participate the ground round with the doctor in the respective wards. So this is the activities of the pharmacists they in the hospital settings in a Dhaka Medical College. Dhaka Medical College affiliated to the Dhaka University. So Then I talk about what is the problems, because we create a daily routine, because usually we took 5 to 6 classes per day per year. First year, second year, third year, fourth year, fifth year. 5 to 6 classes per day. It started from 8 and have to be completed by 2 p.m. But we advise our teachers to make comfortable. If it is not accommodate during the 8 to 12, 2 p.m., you can take in afternoon or in the evening also. But in the middle of the classes, the number of students reduced, and they then giving a written application to me. At that time, I was the head of the department. Then they told me, we are so much tensed, we cannot concentrate the classes because our mental breakup, always we are packed up in the room, we are not able to go out. So they are not mentally stable as well. So that was the creation, that is the problems of the students, because I think that is the main reason the portal would like to concentrate how they can concentrate, because during this matter, because we are always getting information to the patients, to the students, and it is one-sided mostly in the in online sessions, because some of the according to experiments, some of my colleagues, they are not sharing their informations with the PPTs and other documents. And we try our best, have to address the students in the classrooms and ask them, because you see most of the students are in the class, they are not responding. At least 2 or 3 are responding most of the cases. Then I am observing some of them not at all responding. Then by checking the name and addressing them, are you there? Sometimes they are not responding because maybe he or she is sleeping, or may keeping the mobile or keeping the laptop on. He was taking his food or her food, or like this. So that is the problems of the online classes, because physical classes and the online classes far difference. And the teachers, those who are taking classes on board directly, like a physical classes, and asking to the online classes, getting the responses of the students, how much you have gathered information on the specific topics. So little bit is improved than the Power PPT sharing. So regarding these things, both way, the students and the teacher have to be rational in terms of the providing information, because we are not, these classes are not so much participated as we do physically. So depending on a good teacher, those who are much interactive even in online classes, that will be lively, because participation, interaction with the students is very much needed. In that cases, the classes may be more peaceful, more educative, more interactive, and the informations provided by the teacher will be well accepted by the students. And that's why both way participation is very much needed in online classes. So that is my observations and my comments regarding the questions who made these things. Thank you very much.
Thank you, sir, for sharing your profound knowledge with us. It will be a great pleasure for us to listen to you again in our future events.
Definitely. Thank you very much for all of my colleagues, those who are participating. Still, now it is 42, and the students, those who participated through YouTube's and Facebook. Thank you very much to all of them.
Thank you, sir. There is an announcement for the participants. E-certificate will be issued to only those participants who will submit the feedback form and qualify the online assessment. The feedback form has to be filled at the end of each day till 8 p.m. The submission of feedback form shall be counted as their attendance. The online assessment shall be conducted at the end of the stage of STTP. The link for the submission of feedback form has been posted in YouTube chat box and Google Meet chat box. Kindly go through it and submit it. I once again thank you all the dignitaries and participants for their active participation. Tomorrow we'll start our session at sharp 10 a.m. Thank you very much.
Thank you very much, Ruchi Bhattacharya. I think your name is not Ruchi Bhattacharya. I think yesterday is another thing, or Ruchi Bhattacharya. It's okay?
Sir, my name is Ruchi Bhattacharya.
Oh, thank you very much. Thank you very much. Thank you, Ruchi.
Thank you, sir.
Thank you to Colombian Institute of Pharmacy for giving me the opportunity to say something regarding the pharmacy professions and the quality made by the students. Thank you very much to all of you.
Thank you, sir.
Thank you very much.